Paul, I ran into some traffic on the way down here, and I just hate traffic. But Paul, you know what really makes my blood boil?
Tell me.
Crematoriums.
I think about the humiliation ritual that we do every year where we come here in this most prestigious medical institution and then do this. So, Matt, what do you call Matthew Broderick after he takes his iron supplement?
I don't know, Paul.
Ferris Bueller. That's the exact right response. There is medicine stuff too, folks.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of those and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Hi, Paul.
Hi, Matt. How are you?
I'm doing well. Today, we're going to be talking about macrocytic anemia and some variations of that. We're going to go through some cases. We have a great guest, Dr. Rakhi Naik. But before we tell you about her, Paul, what is it that we do on the Curbsiders?
Sure. Thanks for asking, Matt. As a reminder, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. Let me tell you about our expert. We are very lucky to be joined by Dr. Rakhi P. Naik, who is an associate professor of medicine at Johns Hopkins University. She is the clinical director of the Division of Hematology, director of the Fellowship Hematology Track, and director of Organ Systems Foundation of Medicine, the largest pre-clerkship course in the medical school. She holds an undergraduate degree in biomedical and electrical engineering from Duke University, an MD with honors in research from Cornell, and a master's in health science from the Johns Hopkins Bloomberg School of Public Health. Dr. Naik completed her internal medicine residency and hematology fellowship training at Johns Hopkins, where she also served as the assistant chief of service as a chief resident. Dr. Naik serves as the chair of the American Society of Hematology Hematology-Focused Training Program Consortium, which aims to create innovative training pathways and curricula to increase training recruitment into academic hematology. She also tells us that she is a huge fan of hematology puns, but that may have changed in the past 5 minutes. Thrilled to welcome Dr. Naik to the show to talk to us about anemia. And now, thunderous round of applause from the audience, please.
Okay. And Dr. Naik, thank you for joining us. Is it okay if we call you Rakhi for the show? We always go by first names. Keep it casual, you know?
Oh, yeah, absolutely.
Okay. So first question for the audience is, can you tell them a hobby or interest that you have outside of medicine?
Absolutely. So first, actually, I just wanted to thank you for bringing me onto this podcast. One of my resident mentees actually texted me and said, Dr. Naik, you're so cool. And as a really nerdy hematologist, I will tell you, I've been striving to be cool for a very long time. So thank you for letting me achieve that. So in terms of my hobbies, one of them is puns, believe it or not, heme puns. And I think my love of puns actually started in medical school when I joined an a cappella band called the Aneurysms. I think that's where it all started. But of course, I am a hematologist. And so really my love is about hematology puns. And I actually often make them up on the way to work. So I'm going to give you two of my very classic hematology puns. All right, the first one is my division director's favorite. So what do you call a young neutrophil with lead poisoning? A young neutrophil with lead poisoning, anyone? A heavy metal band. Pretty good, right? I know you guys love that one.
She's putting us to shame, Paul.
This is doing way better than ours did. This is not great.
And here's the second one. All right, so a patient got heparin, developed thrombocytopenia, and then never got heparin again. I guess it was a hit and run.
Sorry.
Thank you.
Cut her
Thank
mic.
you. All right. But I just wanted one more thing. I do want to tell you what one of my real hobbies is true crime. And I've been a true crime aficionado for many, many years. In fact, I've been watching Dateline since the 90s. It started in 1992, and I've seen every single episode. So I really am an OG fan of true crime. So that really is one of my other hobbies.
Oh my gosh. Well, I guess you realize that this is being recorded and people are going to hear these puns and hobbies, a cappella group. Yeah, but that's great. You're not afraid to be who you are. That's awesome. Paul, anything else you wanted to ask?
No, I mean, it's hard to me to imagine anything cooler than a cappella punning. But I will ask something we like to ask every one of our guests for any advice or feedback that you've either received or that you give to people who are training with you in your career.
Yeah, for sure. So I am an educator through and through, and I teach all the way from medical school to fellowship. And actually, the advice that I learned is actually from my first year medical students. So one thing first year medical students do is they ask why a lot. And you know what's funny is like once we get through residency and fellowship, we sort of stop asking why. We just say it is how it is. And it turns out that actually knowing the why helps a lot. Even later. And I'll be talking a lot about that when you ask me questions during this podcast, because there's so much going on in medicine right now that there is no way to memorize every single thing. So really understanding the why is super important.
Okay. We are going to get to our first case from Kashlak Memorial, very prestigious hospital. If anyone wants to apply there for residency, you can't because it doesn't exist. Paul?
Sure. We're going to start with Elise. So Elise is a 62-year-old female with a history of obesity, status post Roux-en-Y bypass surgery. She has high blood pressure, CKD 3A without albuminuria, hypothyroidism, gout not on allopurinol, who presents for a follow-up visit. She follows a vegan diet and takes a women's multivitamin, high-dose vitamin D, and B12 supplements. Her pre-appointment labs show a hemoglobin of 10.5, so low, MCV of 102, so high, RDW 15, white blood cell count of 4.2, and platelets are 149. Her TSH is 5.2, creatinine is 1.4, which is about her baseline, and her lipids are normal. So we have a patient who comes in with one of the banes of my existence. I love this framework of always asking why, because I feel like this is one of those abnormalities that you can just kind of let ride for forever without, and just be vaguely nervous about it. So I would love to hear your initial thoughts and approach about someone who has a macrocytosis and sort of where do we go from here?
Perfect. So that's a great question. So again, let's talk about the why. Why does one even develop macrocytosis? So if you remember, macrocytosis is really just based on the size of the cells and its average size of a red cell. So there are two major mechanisms by which you can get this. So the first is going to be, let's say you're just making normal red blood cells, but you're making a lot of some that are bigger. And that's really the mechanism of macrocytosis and reticulocytosis, because retics are like young, they're juicy, they're big. When you have a lot of them out there, the average size then sort of moves towards being macrocytic. So that's one mechanism. And then, of course, the other two mechanisms are really coming from the red cell themselves. So you can make abnormally large red cells for two reasons. Red cells have a membrane. If that membrane is abnormal, so you have abnormal lipid metabolism, you can make these very large red cells. So that's kind of the mechanism in like liver disease, for example. And then there are other mechanisms that have to do with DNA. And that's all that we usually talk about when we're talking about vitamin B12, for example. That is a cofactor in DNA synthesis. And so when we have abnormal DNA, we can grow our cells, but we can't divide them very well. So they become very big, get out of into circulation, but they're not dividing. And so they're just very large abnormal cells.
So in primary care, we look at a lot of labs all day. Is there any cause that we're commonly overlooking and sending to you as a consult? Like, why does this person have macrocytic anemia? You know, this is a chance to just like get us to do the right thing moving forward.
That's a great question. So we often do get a lot of consults for macrocytosis without anemia, or even with just mild anemia. I will say one thing that can happen over time with age is that as you can imagine, we're making more and more red blood cells, and there can be some degree of abnormal cells that come out. So just age itself can lead to some degree of macrocytosis. And then liver disease is really the other one that's often overlooked, where we will go and look for liver disease and find it.
Okay. We could look for liver disease, Paul. I feel like that's in our wheelhouse.
Sure. So I do want to ask, I gave a very meaningful pause after not on allopurinol, as if that might be significant here. Can you talk us through any medications that we should be mindful of when we're actually evaluating patients for macrocytosis?
Yes, absolutely. So this is another one where I'm going to caution you guys not to memorize. Don't memorize. Let's try to think about why do we develop macrocytosis in the first place. And again, one of the major mechanisms that I mentioned to you guys is DNA problems. So anything that's going to cause a problem with DNA synthesis, repair, or polymerization is going to cause some kind of problem with macrocytosis. So things like HIV drugs, which inherently are going against DNA polymerization, are going to cause it. Things like methotrexate that lead to folate metabolism, which is part of the DNA synthesis pathways. Obviously, other types of drugs that can lead to direct toxicity of DNA, like chemotherapy drugs that are intentional for that, those are going to be ones that are going to cause macrocytosis. So again, think about the mechanism, forget about memorization of long lists.
And how much alcohol does someone need to drink in order for us to blame that as the cause?
That's a good question. So how much alcohol? I think that's kind of probably hard. It differs for every individual, but we're really talking about chronic alcohol use, not something like I went out and binge drank for like a night. You're not going to develop macrocytosis immediately, but it tends to be one of these sort of long-standing things. And that's because alcohol leads to lipid problems. So that's going to cause macrocytosis, direct DNA damage. So that's going to lead to macrocytosis. And then, of course, liver disease. So it really hits all of them and can cause macrocytosis over time.
Yeah, because I think I saw some quotes like if people have like half a bottle of wine a night or like 2 stiff drinks per night chronically, that might even be enough, but that it seems like it might go away pretty quickly once they stop.
I think that sounds right. Yeah.
Okay. Well, this is good. I'm learning things here, Paul.
You're doing great.
What else do we want to know about? What other? I guess we can talk about other testing at this point. So, like in most of the time in primary care, if you get a CBC, you're not immediately ordering with that first round of testing, especially if you weren't expecting a macrocytic anemia or macrocytosis without anemia, and you get it back. What should you order as your next round of testing? Now, we've already talked about on the show many times the Williams. Paul, do you want to tell people what the Williams method is?
Sure. The Williams principle is just repeating labs till you like the numbers, which works about 50% of the time, truth be told. So I recommend it unless they go south and then stop doing it. But yeah, no, it's a good question. So I think ordinarily a B12 and maybe a folate, though I know that a lot of hematologists don't like when we do that. So I typically just check a B12. Is there anything else that we should be checking to kind of work this up?
Yeah, I think that's a great question. I like the Williams test because I actually do think that does correct problems many of the times that it gets sent. One thing that I do say about hematology is everybody gets a CBC and it's going to be abnormal one time. So, occasionally just repeating it is the answer to it. So yeah, B12, I would say, is probably the first thing we do tend to check because it's sort of a low-hanging fruit, something that's very easy to then correct. And then, as I mentioned before, things like looking at their medication list, because it could be as simple as what they were taking, or looking for liver disease, which is often an occult finding that sometimes people won't even know that a person has liver disease. But those tend to be the next steps.
Yeah. And when I was reading articles about this, they were saying you should maybe check copper levels. The patient we gave you has had a bypass. Outside of a bypass surgery, is that I don't think I've ever ordered a copper level, or I shouldn't say never, but it's not something that I'm routinely ordering. Is that just should we leave that to you?
I think that, in the case of someone who really does have absorption problems, I think it's reasonable to do. It is something that can cause macrocytosis often. That being said, I agree with you. It's very rare that it is actually the ultimate cause of it. So sometimes leaving it to the hematologist is just fine.
Okay. Yeah. And let's see. What else did we put on our list of things here? So, I guess before we get to talking about maybe who needs a bone marrow biopsy, what else should be on our differential for macrocytic anemia? Like we talked about the main things, liver disease. Dare we talk about Vexus? Can you mention?
I guess we dare too. But I will say that is along the spectrum of clonal problems that can lead to macrocytosis. So in the realm of myelodysplastic syndromes that we will be talking about today. In general, these are mutations that can be acquired through a lifetime in the bone marrow in early stem cells that can ultimately lead to DNA damage and macrocytosis. So that is one of the features of Vexus syndrome, which the syndrome itself, anytime we hear the word syndrome, it often means we don't really understand it. So Vexus syndrome is just a constellation of immunologic findings that are associated with clonal abnormalities.
At the conference this year, anyone who had a chance to mention it, like any topic that was even vaguely related, like the rheumatologist, the hematology updates, they were all talking about this Vexus, and it was vexing to me.
I agree.
Yeah. Okay. All right, Paul, we don't have to worry about Vexus. Well,
I think, we had to mention it to prove that we know what we're talking about, and now we can move past it and not mention it again, ideally.
All right, so I think we can conclude the first case, Paul. So do you want to read the ending of this?
Sure. Yeah, the thrilling conclusion is we go back and revisit a social history because we're good doctors, and then we find out that in addition to being vegan, our patient actually drinks a full bottle of wine each night. So we tell her to please stop doing that. We actually start naltrexone. She cuts back on her drinking. A success all around, and her macrocytosis resolves over time. So a win for Elise.
All right. Now let's go on to a case, a little bit more of a difficult case. And Paul, if you would read it for us.
Happy to. So we're going to talk about Elise's daughter now. This is Jane. Jane is a 40-year-old female without much in the way of past medical history. She's coming in with 1 month of fatigue and dyspnea and exertion. Her teenage son bluntly told her that she looks pale and sickly, which is a nice detail. Jane has an IUD and does not experience regular menses. She is without rectal bleeding. There's no hematemesis. On examination, she looks pale, but she does not look toxic. There is no splenomegaly on examination. We do our best to actually check. Her labs reveal a hemoglobin of 7.5 from a baseline of 12.5 about a year ago. Her MCV is 103, which is big. RDW 23, platelets are 300, white count is 7.5. Ferritin is 150, so not low. TSAT 24%. Total protein 6, albumin 3.5, bili of 2.5, and a creatinine of 1.1. So a lot of numbers there, but the big ticket item is the hemoglobin of 7.5 with an MCV of 103 and then some other abnormalities there as well. So what initial thoughts do you have for Jane with this new anemia?
Yeah, that's a great question. So I'm just going to look at all of the labs here to try to point me in a specific direction. So one thing I can see is for sure the patient has a macrocytic anemia, but no other cytopenias. So that kind of helps me think maybe this is only in the red cell line. The other thing I'm noticing is the high bili. Because that kind of points perhaps to some type of hemolytic anemia. I'm going to say in terms of what are we going to do next in this case? Well, I'm going to check a retic count, okay? Never get a CBC without a retic count. That's a hematologist's advice to you.
Oh, okay. That's all right.
And part of that is because it's going to automatically tell me which category I'm going to be in. Obviously, if we're talking about macrocytosis and it's because of a DNA problem, that reticulocyte count's going to be low. But if we're talking about a hemolytic anemia, it's going to be high. And let me give you another pearl from hematologists is that, in medical school where you have to look at the reticulocyte percentage and do a correction factor, there's all this math going on in your head. You know what? We don't even bother with that.
I love it. This is amazing.
So the reason why we don't bother with it is because we just look at the absolute reticulocyte count. And that either tells me that it's high and appropriate or supra appropriate, or that it's normal and it's low for the anemia, so it's not appropriate. So I just have two categories and I use the absolute retic count for that.
Okay, so let's get you some more labs here for this case.
Sure. The patient's direct bili is 0.5, LDH is 300, and the haptoglobin is low. There is no hemosiderin present in urinalysis. Reticulocyte count is elevated. INR and PTT are normal. The peripheral smear shows many dark red microspherocytes. That sounds bad. Some larger spherocytes and many large irregular reticulocytes. You call to review her labs, and Jane confirms that she has not been marching or playing bongo drums. Great. No spider bites. She does not have weight loss. She is without fevers, night sweats, rashes, joint pain, or lymphadenopathy that she has noticed. So great historical details here that I might not have asked Jane about necessarily, including the bongo drums. So, where do we go from here? So does this change anything for you or talk us through your framework as we move forward?
Yeah, so I will say now we have a bunch of labs that are sort of pointing towards hemolysis. And I think that's the next step for anyone out there. When we have an anemia and you're suspecting hemolysis, get the retic count, get the LDH, get the haptoglobin. Those are going to be helpful to try to put which category is this in. I will say of all the markers, I find indirect bili to be the least sensitive. Sometimes it's up, sometimes it's not. But, having that as part of it is always helpful. So I would say that's definitely the first thing. And then the second thing is obviously to look at the smear. And I'm not going to say everyone should be an expert at looking at smears. Oftentimes, the hematologist has to look at that and really understand what's going on. But in this case, if you were to look at it or a pathologist was to look at it and they saw these little tiny spherocytes, it would automatically point to something in my mind. So that would be autoimmune hemolytic anemia. And let me just tell you something cool about autoimmune hemolytic anemia. So the reason why we get it is because there's an IgG that's bound to the cell. And then the spleen recognizes that IgG membrane complex, eats it, and then the cell reseals itself from its biconcave disc into this beautiful spherocyte. And that's what we see in circulation. Isn't that cool?
Yes. And for those in the audience, we can see some examples of that up here on the slide. That is cool. I like it. So how much do we have to worry about this like spider bite, bongo drum, marching? When I was reading that, I just thought it was a fun historical detail to ask people about.
Yeah, believe it or not. So there is a thing called march hemolysis, which is an actual mechanical hemolysis that can occur in people who are in a marching band or running marathons. Believe it or not, we actually have diagnosed a couple of these in marathon runners.
That's great.
Yeah. So it's an actual thing.
All right, audience, I'm challenging all of you. I want all of you to try to diagnose your first case. Whoever gets it first, Paul will give you a $100 gift card
Absolutely.
to a restaurant of your choice.
Sure. Maybe a patch.
All right. So let's talk a little bit about the next round of testing, if any. Like, what else are we going to need to do, and any other things on our framework here that we need to talk about?
Yeah. So I think, obviously there's many different causes of hemolytic anemia. And most of the time, the good news is that the smear can help differentiate those. But oftentimes, as we mentioned, a hematologist who has a lot of experience looking at the smear may be needed to differentiate between different kinds of cells. But the most common causes tend to be things like autoimmune hemolytic anemia, which will cause spherocytes if it's a worm. It can cause bunches of grapes if it's a cold. And then we can get things like bite cells in G6PD, or what we also call blister cells. We like to do things very descriptively in hematology, as you can see.
Yeah, that's good. That's helpful,
Yeah, so that anyone really can identify the cell just by looking at it and then just coming up with a word that it looks like.
I like that. So I wanted to know about, you see some people talking about like urine hemosiderin, and is it intravascular or extravascular? Is that a framework that you find helpful, or is there a better way to think about to think about like the broad buckets of what's causing hemolysis?
Yeah, I think that it is a useful framework, but that just to understand that most hemolytic anemias actually are not in one category versus the other. Sometimes they have features of both. So for example, if I were to check the urine and there was no heme pigment in the urine, it wouldn't point me towards thinking this person does not have a hemolytic anemia or intravascular hemolysis. It may just be that it's mostly skewed towards extra. So I think it's another piece of the puzzle, but doesn't always tell you the full diagnosis.
Okay. So is it time now to order the direct antiglobulin test? Is that where we're at here? And what is the significance of that test?
Yeah, that's a great question. Yes, it's definitely the time. I will say based solely on the smear there, which shows those spherocytes, and we remember why that happened, we would check a DAT or direct antiglobulin test, which is also known as a direct Coombs test. And so that direct Coombs test is really looking for what is bound to the patient's erythrocytes. And if we remember the Coombs test, when it comes back, it's actually looking for bound IgG, which is what I just said happens in warm autoimmune hemolytic anemia. And it's also looking for bound complement, which can happen in another condition known as cold autoimmune hemolytic anemia. But in this case, given that there's spherocytes around, I'm going to think that this is going to be a warm autoimmune hemolytic anemia with an IgG.
And when you read the articles about this, they talk about the IgG and they talk about, I think it's like CB3, or C3b, something like that. If we have a positive DAT, do we just call the hematologist and like let you guys take it from there? Because it seemed like it could get complicated trying to figure out exactly which type they have if they have a positive test.
Yes, I would definitely recommend getting a hematologist involved at that point. One, because we just think it's so cool and interesting. So we would love to see that case. But of course, also because I think we can help with management and figuring out exactly what's going on.
And Paul and I were talking about this yesterday on our walk home from dinner, which was a nice walk. Yeah. And some of the articles were saying that when you find a hemolytic anemia, the workup can be extensive, like you're checking for viruses. You might even be checking a CT abdomen pelvis. Is not something that would have sprung to mind, like checking a CT, I think it was even chest abdomen pelvis for this. So can you talk us through like what should be our next round of testing after that? We say, okay, we think this is immune related. The direct antiglobulin test is positive. What should we do next?
Yeah, so I think a lot of it is to try to figure out what is the underlying reason that this person developed this autoimmune hemolytic anemia in the first place. And that's where all of that testing comes from. So there's three giant buckets. So autoimmune. So it is actually Coombs positivity, believe it or not, is one of the criteria for lupus. So we oftentimes see lupus patients have either Coombs positivity without hemolysis or actually do have the hemolytic phenotype. And so therefore, we will always check for an autoimmune condition. The other two things are to look for viruses. So we talk about viruses because, as a simplified view, it's like molecular mimicry. Our bodies are going after the virus, but then accidentally cross-react with some of the antigens on our red blood cell. And then the third category are lymphomas. And so lymphomas can be associated with autoimmune hemolytic anemia. I just want to tell everyone that the most common lymphoma that we see associated with this is actually a low-grade lymphoma called CLL, or chronic lymphocytic leukemia. And that is something that may not in and of itself need to be treated, but it is causing the antibody production.
Okay. So you're saying I should or shouldn't order a CT chest abdomen pelvis?
Okay. Well, again, I think I would leave that up to the hematologist as to whether they feel that we need to go all the way there.
Yeah.
Let's not do it in the ER. I'll say that.
Be realistic. They probably have had one recently.
It's true.
Yeah. Paul, I hope you don't mind me sharing this. When Paul sees a patient, they're getting a Lyme test, gabapentin. What else are we adding to CT chest, abdomen, pelvis? We'll add that in there.
Yeah,
what else,
acute
Paul?
Hep stuff.
Acute, yeah, there you
Always, no matter what. Yeah.
Okay.
Yeah, just the fatigue serologies are really my favorite to go after.
Right. You're a great steward, Paul.
Just individually bankrupting the healthcare system. Rakhi, what do we do with this patient? Sort of more broadly, what can you talk to us your approach about management? Do we just start dumping blood into her? Do we bomb her with steroids? Do we just keep checking the labs and pray for the best? Where do we go from here with her?
Yeah, that's a great question. So number one, we saw that this patient has a very acute anemia. So let's say they came into your primary care clinic and the patient is very fatigued. We have no idea what part of the trajectory this patient is. Did they just develop this and it's on its way down, or has it now stabilized in this area? So I would say with that much of a drop in hemoglobin, you might be thinking about potentially putting the patient in the hospital. And part of the reason for that is because if, let's say, this is an acute hemolysis that's now going down quickly, you may need to give blood. So some of the things to just think about in terms of giving blood in patients who have autoimmune hemolytic anemia is that we have all of these IgG antibodies that are like floating around. And when we try and type and cross blood for a patient, there's these antibodies that are around that can bind to not only the patient's cells, but they also bind to any other cell that is given to them. And so you'll find out that you can't find a cross-match compatible unit.
That sounds bad.
Yeah, it sounds bad. But the one thing to note is that, yes, these are non-specific antibodies that are around. It usually doesn't create a problem. So even if we can't find, and we know that these antibodies are going to react to anything that I transfuse, you don't want to withhold blood because this patient can rapidly deteriorate if they continue to hemolyze. So you want to give blood anyway. You can just give best match blood, like O negative.
Okay, that sounds good. And like this patient, she's coming in, she's non-toxic appearing. She's just sort of like fatigued and having some like low-grade symptoms. If we happen to order the direct antiglobulin test and she's an outpatient, is this someone we would be admitting to the hospital for treatment potentially?
Yeah, again, it depends on her trajectory and symptoms. Sometimes you can just send straight to the hematologist, especially if you've had a couple labs where it looks like it's sort of smoldering low. And then go to the hematologist. In general, we tend to start steroids as first-line therapy.
Yeah. This seems like one where I would probably be like calling you to see if you could see her within a couple days, not like put in the consult, cross my fingers that you see her within a week or two.
Sure.
Yeah.
That sounds right. And I think all of it, and with most things, we really care mostly about the trajectory, right? How fast is it happening? Because that's going to ultimately lead to the symptoms.
And one other thing I was reading about here that wasn't exactly on my radar. Well, let's say that she calls us and we're checking in how she's doing. Maybe she started steroids, so she saw you, but she's saying she went on a long car ride. She's got some swelling in her right leg. Are clots a big issue for these patients?
I think it's bad.
I think that does sound bad. So yes, hemolysis can actually lead to an increased risk of clotting. And we often forget about red cells, when we're talking about clotting. But in fact, when we have abnormal membranes, like we do with spherocytes, like we do with sickle cell disease or any other membrane abnormality, what ends up happening is that you get externalization of some of the lipids that should be inside of your membrane, and they are externalized out. And they can actually activate the coagulation cascade directly on the membrane of a red cell. Isn't that crazy? And so therefore, you're at risk of developing a clot.
So are you putting some of these patients on thromboprophylaxis even as an outpatient, like chemical enoxaparin or something like that?
That's a good question. It tends to depend on how severe the hemolysis is. But in general, in an outpatient setting, we don't do it up front.
Okay. So let's say we start her on steroids. She responds well. What can we tell them at the beginning of this? Like, we'll say for this case, it's a happy ending. She responds well and the hemolysis goes down. But what other therapies are on the table, or even is splenectomy something that's still being done for this if they have warm autoimmune hemolytic anemia?
Yeah, it's a great question. So we generally start with steroids, 1 milligram per kilogram, because that's our dosing for everything. And it takes about a week to 2 weeks to really get a response. So we know it can be slow. And about 80% of people are going to respond upfront to steroids alone. But the biggest problem ends up being with taper. So a lot of people will respond upfront, but they're not going to have a durable response. So we really are usually looking for second line therapies in most patients. And that second line therapy tends to be rituximab. And then we still have splenectomy in the back of our pockets. So we do that sometimes.
I imagine it's variable, but can you tell me a little bit about like the natural history? Like, let's say we get this patient sort of back to her baseline with whatever treatment that we sort of land on. Like, how likely is this to recur? Sort of what does this look like in the long term for these patients?
Yeah. So as I mentioned, majority of patients will relapse with taper of the steroids. So it's very unusual that steroids alone are going to be enough. Occasionally, let's say it was like a virus that triggered it. For example, I've had a COVID patient who developed autoimmune hemolytic anemia. And then once the COVID got improved, the autoimmune hemolytic anemia also did with steroids alone. But by and large, it tends to require second line therapy. And so we usually will counsel patients up front that you're going to need something more. And then rituximab tends to have about a 60% response rate after that. And again, if you fail that, then there aren't great other therapies. And sometimes we will be looking towards splenectomy.
Yeah, I guess the one outpatient I had that developed this was a woman who she was doing really well. Then she developed this, and it was a long issue. She was on and off steroids, and I think she ended up going for splenectomy ultimately, but it was not good. But our patient here, Jane, she did much better. So we fixed her. So and we have one more case that we would like to get to. So Paul, I'll ask if you would read it.
Sure. Just an unfortunate family, really. So we have Mark now, who is Elisa's husband for the past 40 years. That's not the unfortunate part. Mark is a 68-year-old gentleman. He's got a history of high blood pressure, CKD3B, type 2 diabetes on metformin monotherapy, history of vitamin B12 deficiency, perhaps from the metformin, a BMI of 29, mild anemia with a baseline hemoglobin of 11.5 for years, and mild thrombocytopenia with a baseline platelet count in the 140s typically. He's presenting for his annual follow-up at his wife's behest. He has some low energy, as do all of our patients, that he attributes to being out of shape. No recent infections that he can recall. He does not drink alcohol or use other substances. On exam, he does not have any mucosal ulcers, no gingivitis, no hepatosplenomegaly, no lymphadenopathy, because we do an incredible physical exam, apparently. The pre-visit labs done before this visit show a normal TSAT, normal ferritin, normal B12. Hemoglobin remains low at 10.8, MCV is 97, RDW is 18, the platelets are now at 120, and the white count is 5.2. So we have this patient who has some cell lines that are sort of chronically low to getting slightly lower, and I guess first question is, how nervous should we be about this, and how do you think about a patient who presents like this? Because this seems very, very common to me.
Yes, for sure. This is a very common thing that we often see in a hematology clinic, and I'm sure you all see in primary care clinics. So we'll see this sort of smoldering cytopenias that develop, maybe a little bit of macrocytosis. And often on our differential, we start thinking about NDS. So in this patient, we're looking at them. They don't have the liver disease. They don't have B12 deficiency. Now we're worried, this patient's a little bit older, that maybe they developed a mutation in their marrow that is causing myelodysplastic syndrome. So again, let's go back to what myelodysplastic syndrome actually stands for. So it's really just a fancy term for abnormal maturation of the myeloid stem cells, right? Myelodysplastic. But then you will hear that at the end of that, there's syndrome, which again means we have no idea, and that there's a lot of heterogeneity there in terms of this disease. So we have the NDS that can be smoldering for many, many, many years, and then we can have NDS that is rapidly progressing and can go to acute leukemia. And I think that's why primary care doctors and a lot of physicians get scared. But there's really no reason to get scared. I will tell you that, because a lot of it really depends on trajectory.
Yeah, and you were telling us beforehand about how there's like some people are on a hematology track in the fellowship, some people are on the oncology track. If MDS falls into the hematology track, I understand why, because looking at the classification system as a non-hematologist was just like, I could not follow it. It's all about cytogenetic abnormalities and mutations. It seemed very complicated.
Yes, and I agree with that. There's a lot of scoring systems to try to put you in a specific category of MDS. So are you on the low grade spectrum? Are you on the high grade spectrum? But basically, I think for the audience to know in terms of what do we care the most about, all of these scoring systems involve cytopenias. How many do you have? So, right, this is a stem cell disorder, so it can affect all 3 lines. So it depends, is it only affecting 1 line or is it affecting all 3? The second thing is, how severe is it? If they are severe cytopenias, get more worried. This patient happens to have relatively mild cytopenias. And then the third thing is these sort of mutational analysis. But I would say in terms of what are you going to look at in the clinic, you're going to care about how many lines is it affecting and how fast is it happening, because that's going to really help put you on which side of the spectrum are you there on.
Okay, I'm sure the audience is disappointed. They wanted us to go through each cytogenetic abnormality in detail and ask them to memorize it. But this is good. I like this. Anytime you can make things simple for Paul and I, we're very grateful, because we don't like to get into that kind of detail.
Yeah, I would say you mentioned, primary care doctors getting scared. I should tell you, I'm just scared at my baseline. Like, this is not, it's not, the lab is not going to really tip me one way or the other. I'm already very, very anxious. But I guess along those lines, and I know this is going to be very individual, but do you have any tips as sort of when we should pull the trigger in terms of sort of the more advanced workup? Like, when should we think, okay, this person definitely needs a hematologist versus they should not? And obviously there's a lot of patient factors that go into it. But when you mentioned some of them, but when should we start? When should I be even more scared than I typically am?
Yeah, that's a great question. So I would say, we already talked about the cytopenias themselves, which is one aspect of it, but the differential can help you a lot. So, obviously if you're seeing a ton of immature cells, things that are either young, unidentified blasts, or maybe some earlier myelocytes. If you're seeing a lot of those come out, you might start worrying a little bit more that this is a more high-grade process. The other ones really are, as what I was talking about before, which is trajectory and age of the patient. So sometimes I worry more if the patient is much younger than I worry if the patient is older. Why is that? Because this is a disease of aging. As we replicate our DNA over and over and over and over again in the bone marrow, we're bound to make mistakes. But when you make those mistakes really early in life, it usually portends a poorer prognosis. So I look at age a lot. And then again, how many years has it been going on? If it's been going on for years and not really moving anywhere, well, you know what? I have a lot of time to think about it and not necessarily panic.
I think I see a lot of patients with a very mild anemia. Maybe their platelets are in the 140s, kind of like the case we're presenting here. And some patients are very alarmed that they see red on their printout that they get, and they want to see a hematologist. And other patients are just like, do you think I need to go see anybody? I feel fine. And in some cases, I'll be honest, I'm just monitoring that every 6 to 12 months and monitoring for symptoms and not referring, especially for my patients that are in their 70s or 80s and they're already seeing 4 doctors and they don't want to add a 5th doctor to the. Does that sound reasonable, or is this malpractice? It's okay. No one's listening.
Yeah, luckily this isn't recorded or anything.
It's definitely not malpractice. I think that's the exact right approach. And I will say, sometimes I'm tempted to show patients my own CBC to show them that perhaps there's a lot of yellow that occurs. Where very few patients are actually completely in the normal range. I don't actually do that of note, but I should. But yes, I think this is the best approach in terms of just seeing what the trajectory is and then just deciding whether or not you need to send to a hematologist.
I think it's a great approach. You think yours is bad, check out this, and then just sort of share it with the patient.
And then from a patient perspective, explaining this to them, when you talk to them about MDS, you say, if they're asymptomatic, that seems like an easier decision. What do you tell them on the end of the spectrum, what to look out for, and what's the worst case scenario with this? What does it progress to?
Yeah, I think that's a great question. I will say that this is actually a very nuanced conversation and really depends a lot on the patient. I have a lot of patients who are older, who don't really want to ultimately get treatment. And so therefore my conversation with them will be tailored to that. So for example, MDS can be all the way from low grade, where we only give EPO shots, that's the treatment, to all the way to chemotherapy or bone marrow transplant. So if we have a patient who's much older and I'm suspecting MDS, I will have a shared decision-making with them. What do you think you're going to be able to tolerate? Do you even want to get chemotherapy later in life? And that will maybe skew me towards whether or not I'm actually going to do a bone marrow biopsy and figure out what's going on or not. Because if I'm only going to be using these low-grade therapies like EPO anyway, it perhaps doesn't add much value to do a marrow. So I think in general, I tend to have the conversation tailored to the patient in terms of what type of MDS do I think they have? What do I think they're going to be able to tolerate? And then we will determine next steps together. I will be honest with you, I don't marrow all my patients. And that's because in terms of shared decision making, we're sometimes talking about 2 to 3 years before something is going to progress. If the patient only has a year or 2 left in life, just like with anything else, we may not even want to go down that road.
Yeah, I feel like I have a couple 90-something-year-old patients who almost certainly MDS, but in terms of bone marrow biopsy, it just shrugs all around. I'm not sure what we're doing here. So it's just we've deferred it for, I think, years now at this point.
Absolutely. And that is not malpractice. That is good practice of medicine.
Let's read a little bit more about the case. So a peripheral smear shows he has variable RBC size, normal appearing platelets, no blasts are present, and his wife read about MDS online, and she wants to know if he needs this bone marrow biopsy or just any other testing. You know, I saw stuff about testing for heavy metals and HIV, parvovirus, that sort of thing. So any other testing that you would recommend?
Yeah, that's a great question. You know, one thing we would never want to miss is B12 deficiency and marrow a patient because it was B12. Okay. So in general, I tend to do B12 up front in most patients. And if I do assume that they have some kind of nutritional absorption issue, I will do copper, because the last thing you want to do is to stick a needle in someone and find out that it was actually just a nutritional deficiency that you could have corrected.
Okay. So like kind of back to the macrocytic anemia workup that we talked about initially.
Exactly.
Okay.
And just remember that in that kind of in that scenario, again, all of these, like vitamin B12, is actually causing a DNA synthesis problem, right?
Yeah.
So it's very early. So it can actually cause pancytopenia. It's not just in the red cell line.
We'll make sure Mark's not splitting a bottle of wine with his wife, and that's why this is the way it is.
I think that's another great thing to ask up front. But yes, I think in terms of, again, we would have that nuanced conversation about what do we think you're going to be able to tolerate based on his comorbidities, what are his goals, and then decide whether we wanted to do a bone marrow up front to just prognosticate. One other thing I would say, though, is that bone marrow biopsies, although we consider pathology to be the end-all be-all, is that it still requires a human to look at the cells themselves and decide whether they look quote-unquote dysplastic or not. So sometimes if you have very mild cytopenias and then you marrow a patient, they may not actually look overtly dysplastic, and you're going to get a sort of descriptive, non-helpful bone marrow biopsy specimen. So oftentimes I will wait until there's a reason to treat before I do the marrow so that I actually get a true diagnosis.
That sounds good. I can get him on board with all this stuff. So we'll say Mark, we decided not to perform any specific treatment, and he's happy to just have us follow it. He doesn't want to go through too much extra testing. So I think at this point, Paul, do you have any other questions, or should we take some audience questions?
I think we're ready for audience questions if we have some.
Yeah. And so we can take audience questions. We will repeat them on mic so that everyone can hear on the Zoom. But if anyone has any questions for Dr. Naik, we can take them now. And if not, we can just, Paul and I can do an outro and everyone can go get some breakfast. Yes.
So just to repeat for the general audience, the questions about folate supplementation. A lot of patients, I want to make sure I'm understanding, get started on folate in the hospital and then it's continued in perpetuity when they already have 27 different medications. And what's the utility? So can you just talk us through your approach to folate supplementation? Because I think on a previous episode, we heard that one good hospital meal will replete your folate. So what are we doing and how should we manage that in general?
Yeah, so I think that's a great question. So as you mentioned, folate deficiency, true folate deficiency is very uncommon. It really only occurs in patients who are very malnourished. So sometimes we will, with people who have alcohol use disorder and use alcohol as the sole source of their food intake, are the ones who are the most prone to actual true folate deficiency. The other situation which we may see folate deficiency is when you have a hemolytic anemia, where you're doing a lot of replication, you need more folate there. So those are really the two circumstances in which folate supplementation is going to be helpful, because as was just mentioned, many things are supplemented with folate. So if you're having a normal diet, you unlikely are going to need additional folate. So in general, I would recommend against adding it to their pill box because patients don't need more pills.
And I've pretty much stopped testing for folate, probably more malpractice on my part, but do you test folate? Do you send it for the two cases you just mentioned? Are you checking folate, or are you just repleting because it doesn't matter if you're going to replete anyway?
I tend to just replete. So
Okay.
You guys have been listening to hematologists.
Yeah, Paul, I like this. I like this approach. Yeah, just give them the folate. You don't have to check the folate. I like that approach. Any other questions? Yes, sir. Okay, so that was a question about future of bone marrow biopsies. Is there a way to biopsy the marrow without really biopsying the marrow?
Yeah, that's a great question. You know, we actually are moving more and more away from doing bone marrow biopsies because a lot of times these abnormal cells are actually found in the periphery, and we can use genetic tests to, especially things like next generation sequencing, to be able to put people in specific categories. So we definitely are moving away from that. I no longer marrow a lot of my myeloproliferative disorder patients, like, for example, people have polycythemia vera, essential thrombocythemia, even CML, like chronic myelogenous leukemia, because everything is out in the periphery. There still is utility in doing bone marrow biopsies in some cases, many cases, because some of the mutations stay in the marrow. So some of these dysplastic mutations, what they'll do is they'll not allow the cells to mature enough to actually leave the marrow. And so therefore, we're not getting all of the information outside of the marrow. So I think, it's on an individual case-by-case basis, but I think this is a great question. And I think we are moving away from doing it in a lot of diseases.
Okay. Another question? Yes, ma'am. So this was a question about endobariatrics and bariatric surgery and kind of preventing macrocytosis anemias before we see them. What's your approach there?
Yeah, I think, in the setting of bariatric surgery, for sure, getting ahead of nutritional deficiencies is always a way to go about it. I think most bariatric surgeons actually do have a clear plan in terms of looking at nutritional deficiencies going forward. And so we tend to advocate for that because you never want to get to the point of developing macrocytosis. As we remember, B12 deficiency can also cause neurologic issues. So you never want to get to that point. Being ahead of it is the best way to deal with it.
I definitely see some patients, they're 5 years out, 10 years out, and they fall off the wagon with their vitamins. And I am seeing the anemias. Usually in the beginning, right after surgery, people are more likely to be taking things. Paul, as America's PCP, what are you seeing the same thing?
Yeah, no. Well, I think we've talked about this before too. You tend to get the handoff eventually. Eventually, they stop going back to their bariatric surgeon, and the micronutrient deficiency testing kind of falls into your lap. So it's worth knowing what to look for and when to look for it.
Yeah. Okay. Any other questions? Yes, sir. So the question is about repleting folate and then maybe missing a B12 deficiency, or is there any other testing we should do for B12 deficiency?
Yeah, so those are great questions. So what you're alluding to is patients who are given folate supplementation. What B12 is required for is to demethylate folate. Okay. And when we are given supplements, we no longer need that B12. And so therefore, you may see improvement in the anemia, but you will see continued progression of the neurologic findings because you're not really dealing with the B12 deficiency. So you may accidentally mask that you're doing a good thing by making the red blood cell count get better. So yes, that is definitely a theoretic concern. And I think that's a great point as to why we shouldn't just replete folate without looking for B12 deficiency first. And then in terms of B12 deficiency, other things to look for, B12 is actually looking for two different types of B12 in the serum. And so therefore, sometimes true B12 deficiency will require other metabolites for us to look for. MMA tends to be the most sensitive. So methylmalonic acid, generally, I tend to send both of them together if I'm really suspecting it because B12 and MMA can take a while to come back. So I tend to send them at the same time so that I'll get everything back.
This is another good pearl, Paul. I like that.
I was really worried we're going to have to worry about methylmalonic acid, but yeah, all right, fine. I'll do it if I have to.
Okay. Well, thank you everybody for all your questions. At this point, Paul, I think we should just get out of here, do an outro.
Sure. Any take-home points for our listeners, Dr.
Yeah, let's do that first.
Anything that you would like the general internists to know about what they should be doing before they send folks to you, before we let you go?
All right, perfect. I'm going to just say, again, think about the pathophysiology because that'll help you figure out what you need to test for in terms of macrocytosis before you send to the hematologist. Because if it is liver disease, that should go to the hepatologist.
Okay. And once more, another round of applause for our wonderful guests.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
All right. Didn't even give the audience a chance to do it, but All right. Still hungry for more? Join our Patreon. You can get our episodes ad-free, plus twice monthly bonus episodes at Curbsiders.com. You can find our show notes at Curbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes the Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge, so we want your feedback. Email us at askcurbsiders@gmail.com. It also helps when you subscribe, rate, and review the show on YouTube, Spotify, Apple Podcasts. A special thanks to our whole Curbsiders team. Our production is done by Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Chris the Chew Man Chew moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
And as always, I'm Dr. Paul Nelson Williams. Thanks and goodbye.